All right, so let's get started. Hello, everyone, and welcome to Symposium Session 3, the long-term effects of radiation disasters. My name is Jonine Bernstein, and I'm an epidemiologist at Memorial Sloan Kettering Cancer Center in New York City. I am pleased to introduce my co-chair, Julie Burt, who will be monitoring the Q&A. Julie is a radiation biologist working for the Canadian Nuclear Regulator. Her research centers on the effects of low-dose radiation exposures with a focus on modeling the potential consequences of nuclear accidents. In her spare time, Julie is working on her PhD incorporating social sciences and humanities into radiation protection measures. So on behalf of both of us, we want to welcome you and introduce our wonderful lineup of international speakers for this session. Our first speaker will be Dr. Dmitry Bazika from the National Academy of Medical Sciences of the Ukraine. His talk will focus on the late health effects in cleanup workers following the Chernobyl accident. Dr. Bazika is the Director General of the National Research Center for Radiation Medicine, the RCRM, in the Ukraine, where he has been since 1987, working first as a senior scientific officer in the clinical immunology lab, then serving as head of the immunocytology lab, then as head of the clinical immunology department, and then serving as vice director general of the RCRM, responsible for all scientific research. And then over the past decade, since 2011, he has served as the director general of the RCRM. So over this 34 years in radiation medicine and radiobiology since the Chernobyl accident, Dr. Bazika's research has therefore focused on everything from immunology to flow cytometry in acute radiation syndrome, leukemia, and other cellular effects to the epidemiology of leukemia, multiple myeloma, and thyroid cancer in radiation exposed people. Dr. Bazika is a member of the National Academy of Medicine of the Ukraine since 2016, and he's been a representative of the Ukraine to UNSCEAR since 2012. He's published over 186 peer-reviewed papers on radiation medicine, radiobiology, and radiation protection. And he co-authored national reports of the Ukraine on Chernobyl in 2001, 2006, 2011, 2016, and 2021. And he serves as the editor-in-chief of the Problems of Radiation Medicine and Radiobiology. Our second speaker is Dr. Maureen Hatch, who recently retired after close to 20 years in the radiation epidemiology branch of the National Cancer Institute, where her work focused on risks associated with exposures in the prenatal period. After receiving her PhD in 1983 from Columbia, Dr. Hatch studied risks of cancer following the 3 Mile Island nuclear accident, where she published several landmark articles on cancer risk. In 2002, she joined NCI's Chernobyl Research Unit and in collaboration with the Institute of Endocrinology and Metabolism in the Ukraine, established a cohort of 2,600 in utero exposed individuals who have since been followed for the incidence of thyroid cancer and other late effects. Dr. Hatch has published over 160 peer-reviewed papers and is an editor emerita of the American Journal of Epidemiology. Today, Dr. Hatch will speak about the late effects of Chernobyl fallout in those exposed prenatally as children and adolescents. Our third speaker will be Dr. Sumanora Akiba from Hirosaki University in Japan, and his talk will be on the Fukushima accident, levels and effects of radiation exposure. Dr. Akiba is an established and well-known epidemiologist in Japan who is well published. His career highlights include serving as research associate and then later as assistant chief in the Department of Epidemiology at the RRS in Hiroshima, Japan. He then became chair of the Department of Epidemiology and Preventive Medicine at the Kagoshima University Graduate School of Medicine, Medical and Dental Sciences in Kagoshima, Japan, where he was until 2017, when he became a senior scientist at the Health Research Foundation in Kyoto, Japan. He still is there, in addition to joining the faculty at the Hirosaki University in Hirosaki, Japan since 2019. And then to tie the session together, we are truly fortunate to have Dr. Norm Coleman as our discussant. Dr. Coleman is Associate Director of the NCI Radiation Research Program in the Division of Cancer Treatment and Diagnosis and senior investigator in the Radiation Oncology Branch in the Center for Cancer Research at NCI. He is also a senior medical advisor in the Office of the Assistant Secretary for Preparedness and Response in the U.S. Department of Health and Human Services. He received his MD from Yale and is board certified in internal medicine, medical oncology, and radiation oncology. Until 1999, he was tenured member in radiology and medicine at Stanford and chairman of the Joint Center for Radiation Therapy at Harvard. He has an ongoing NCI laboratory program in radiation-inducible molecular targets and radiation biomarkers of normal tissue injury. Among his numerous honors, he has received the gold medal from ASTRO in 2005, the 2011 Service to American Homeland Security Medal, and the Radiation Research Society FIA Award in 2016. So please join Julie and me in welcoming this truly spectacular lineup of speakers. To ask a question just during the talk, please use the Q&A function and be sure to indicate who you're directing your question to. The Q&A will be after the talks, but feel free to write your questions as they occur to you. So Dimitri, let's begin. Please take it away.
Hello to everybody. First of all, I want to thank you for inviting myself to present our data on Chernobyl. Now it's 35 years after Chernobyl, and it's time of late effects. On this slide, I show the number of registered cleanup workers in Ukraine. It's more than 300,000. From them, 200,000 were workers of the first year of 1986 and 87, and 134 were survivors after acute radiation syndrome. This number was used to form several scientific cohorts. First of all, the cohort on leukemia and thyroid cancer from 152,000 male cleanup workers. It was constructed and used together by the RCRM and the National Cancer Institute of the United States. Of them, 68,000 were cleanup workers with official dose records. 16,000 were female cleanup workers. 8,000 were used for study of UACOS study on radiation cataracts. Also, we have an extended clinical epidemiological register of the RCRM with more than 10,000 cleanup workers that are studied with the extended analysis to have information on the mechanism of radiation effects. Also, we have the database on the Central Interagency Expert Council on the dependence of health loss due to Chernobyl. It's more social cohort, but it's rather big and collects a lot of information, more than 60,000 cases. This cohort enabled to make studies of the late effects in cleanup workers. These are effects when exposed to high doses. Descriptive studies showed effects like leukemia, lymphoma, multiple myeloma, thyroid cancer, breast cancer, other solid cancers, cardio and cerebrovascular incidence and mortality. Much fewer are analytic radiation risk studies, which have been performed mainly by RCRM and the National Cancer Institute These are studies on leukemia, on multiple myeloma, on thyroid cancer, on cognitive function and radiation cataracts. Starting from acute radiation syndrome, I want to say that these survivors were studied and followed up in our CRM since 1986. Now the number is decreased due to death, and the main causes of late death after acute radiation syndrome were cancers and leukemia, cardiovascular diseases, other somatic neurological diseases, including tuberculosis, traumas, and accidents. Here you can see this cohort was very popular for many people, and here you can see Dr. Hans Blix, head of the IAA, with these patients in our center. First of all, I want to speak about the radiation cataracts. Frequency rates of radiation cataracts showed dependency on the dose and stage of the acute radiation syndrome. If in acute, not confirmed acute radiation syndrome, radiation cataracts were shown only in 4%, less than 5%. And in those who have acute radiation syndrome, third stage, 100%. Involution cataracts, frequency rates didn't show any dependency on age and radiation dose. The Ukrainian-American Chernobyl ocular study showed that radiation lens opacities could be found also at low dose and rates. And for most of part, the doses were less than 0.5 gray. Obtained data led to a change in professional limits of cataracts induction, and this was adopted by the ACRP as a 20 milligray limit. Leukemia. This is the study that was very big study, and it was one of the biggest study in radiation leukemia. So we have shown the ERR for 1 gray S344, and for 20 years after the irradiation, the ERR per gray was 238. So this was published in studies, and what was interesting, the rates for CLL and non-CLL leukemia were almost the same. We have compared our data in cleanup wars with other studies. Our studies showed almost the same radiation risks as other studies, as Chernobyl cleanup worker studies, as lifespan study, and Russian liquidator study. The difference was that we have shown the effects in chronic lymphocytic leukemia. Here you can see doses, a period of before the year 2000, 15 years after the exposure, and 20 years after the exposure. The higher is dose, the earlier is non-CLL leukemia. And CLL seems to be induced in lower doses than non-CLL leukemia. We have performed also an incidence ratio study in the leukemias till the year 2012, and also found increased standardized incidence ratios for all period and for separate period of 1996, from the first 10 years, the second 10 years, and the last period till the year 2012. So we tried to make some analysis of this radiation-induced CLL. This study provided new evidence on the association of radiation dose at young age at first radiation exposure with shorter survival after diagnosis, changes in telomere length and gene expression, which was performed in 17 samples from cleanup workers, 29 samples from non-exposed from Ukraine, and 100 samples still from US. No difference was found between Ukrainian and US CLL, and difference was between exposed and non-exposed. Here I show the genomic landscape of this study. The cancer descriptive studies, several studies being performed in the cohort, and we have shown the standardized incidence rates for multiple myeloma and for thyroid cancer. Of course, these are descriptive studies, and these studies have to be confirmed by the analytical studies. Also, we have shown the incidence ratios for thyroid cancer in different groups of Ukrainian population affected by the Chernobyl accident. And the most prominent increase was in recovery operation workers. Comparing different studies, I can say that the studies have very close results, except of our latest study, which was led by Dr. Cahoon, and we have shown only borderline increase in thyroid cancer in cleanup workers. For female breast cancer, the difference of cleanup workers is significant till now, and we find the increased standardized incidence ratios. On cancer effects. Later, on cancer effects other than radiation cataracts are hot topic and are disputable. The 8-country meta-analysis demonstrated an increase in cardiovascular mortality in cleanup workers. Previous data have shown effects after exposure to doses over 500 milligram. New approaches demonstrate effect at low dose range of coronary heart disease at 150 plus milligram and cognitive deficiency at 100 milligram and more. Here also additional studies are in need. I show here several slides of non-cancer effects. Here we can see the incidence rate decreased. It's understandable because a lot of people have disease, and mortality is increased also in those cleanup workers who are younger than 40 years and those who are older than 40 years. Mortality is increased. The updated analysis demonstrates also the excess-related and excess absolute radiation risk of coronary heart disease in Chernobyl cleanup workers of 1986-87. Cases of cerebrovascular diseases were excluded from the analysis. I can say this study was based on the official doses, official dose records, and also it needs to be confirmed by analytical doses and modern methods of dose reconstruction. Also very interesting is evacuees group. Circulatory diseases in evacuees groups show effect on those to thyroid, on the risk on circulatory diseases. Risks are connected who is aged from 18 to 39 years at the time of accident, and these people prove to be more susceptible to ionizing radiation. Comparison of risks for circulatory diseases by a certain time revealed significant risk for arterial hypertension in the younger age group, in coronary heart disease and cerebrovascular disease in people aged 40 to 60 in the time of accident, with the doses, steroid doses from 0.3 to 0.75 gray. A lot of studies, a lot of ideas were proposed to explain the cognitive disorders after Chernobyl. So these are vegetative dysfunction and electrophysiological background by Professor Nyago, radiation encephalopathy as a result of direct influence on brain, change receptor binding and expression of result of interaction of nervous and immune system. Epidemiological studies show the mental problems in Gomel region using the GHQ and Munich diagnostic checklist. This was done by Dr. Havanar. And Nyago and Loganovsky showed prevalence of depression reactions in cleanup workers as compared with general population. Dose dependency in all these studies was not shown. This is the question: are cognitive disorders induced by ionizing radiation per se, or do they have combined with other non-cancer effects? Here we can show you different pathology that is associated with cognitive deficiency. A study of cerebral has been performed, and more than 300 Chernobyl cleanup workers divided in 5 dose groups were tested for cognitive dysfunction. No external control was used, age standardized, non-exposed control included. So you see the groups, and what was interesting, the changes registered by the general psychoneurological scales like BPRS, DSS, self-estimation test, Wechsler test, were significant at doses over 100 millisievert. Here I show these groups and the mean scores by GHQ-28. So you can see that those who have higher doses have more differences. So also these studies were combined with biomarker studies. Certain parameters related to regulation of apoptosis, cell transcription, angiogenesis, immune function, and could serve as biomarkers at late period. Here we show those genes that we have found. In cleanup workers, the cerebrovascular disease and impaired cognitive function were associated with changes in telomere length, TERF1, TC, and D1 gene regulation. For other cancers, for CLL, POT1, ATM, MED12, SF3, BID, NOTCH1, XPO, and telomere elongation. For breast cancer, upregulation of several microRNAs and downregulation of some genes. In summary, we can say that what we have found, leukemia, radiation risks in cleanup workers are comparable with tobacco data, and we have found the CLL radiation risk. For thyroid cancer, increased incidence in exposed as cleanup workers. For other solid cancers, incidence rates still significantly increased. For breast cancer, standardized incidence rates in female cleanup workers remain increased. For cardiovascular pathology and cognitive deficits, a significant increase in cleanup workers at radiation doses over 100 millisievert and higher, and increased risk of radiation cataracts. What we think about future? We expect increased rates of thyroid, breast, colon, lung cancer, multiple myeloma, reduction of radiation risk of leukemia to population levels, increased morbidity and mortality of cleanup workers from non-cancer diseases in the first place, cardio and cerebrovascular pathology and related cognitive dysfunction. Analytical cohort and case control studies are in need on circulation pathology, late high dose effects, specific targets of radiogenic cancer using molecular epidemiology approach. And at the end, I want to thank all the scientists. First of all, our center and US National Cancer Institute, the Columbia University, Ukraine State Chernobyl Registry, Ukraine National Cancer Registry, University of California in San Francisco, Nagasaki University, Bundeswehr Institute of Radiobiology, and Helmholtz Centrum in München. Thank you for your attention.
Thank you so much, Dr. Bazika, for that wonderful talk. Janine, would you like to do a couple questions now?
Yes, please.
You still have time?
Sure,
Yes.
go ahead.
Great. So I do have one. I'll start with the one in the chat. Have you noticed an increase in colon cancer?
We see only the tendency of increasing. It's a late cancer, so we wait the increase and excess this years, maybe to 40 years and 45 years after the accident.
And that's specific to the workers as opposed to the population.
Yeah. I speak now on the workers.
Yeah. I have a question for you. With regards to the biomarker studies that you had mentioned, was there anything striking for you that were either strong commonalities or maybe very distinct differences with other studies looking at the same biomarkers?
We tried to find the changes in the most important pathways, because our idea was not to find the specific biomarkers like FDXR or Xeroderma pigmentosum genes. We tried to find those genes that are related to apoptosis, that are related to autophagy. Now we work with this, and we find the differences with non-exposed, and also we find the difference due to radiation dose, not direct changes in genes and gene expression, for example, and radiation dose, but these changes are seen in the groups of exposed, divided by dose. This is almost the same that was found in other groups exposed in these doses.
Mm-hmm. And I think we have time for just one more quick question. This will be the last one, but if anyone has additional questions for Dr. Bazika, please feel free to add them to the Q&A. We might get to them later. Given that cardiovascular disease is such a hot topic right now, can you comment a little bit on where you think things should go with regards to the research? You had mentioned that cardiovascular disease was one of the main causes of death after the acute radiation syndrome. Could you elaborate on that?
Yes, I can say that we have found cardiovascular diseases in survivors after acute radiation syndrome. And these cardiovascular diseases are one of the main causes of mortality of these people. Also, you see, when we look at the percentage of cardiovascular mortality or cancer mortality, they are quite similar to those that are shown in European population study. But in Ukraine, people in general have the life expectancy less than in West Europe, for example, for 10 years and more. So this would and make some changes to the radiation risk when calculating the radiation risk. Of course, we also performed a lot of study on low dose. And these studies were started 10 years after the accident, and they are promoted till now. We see, but there is a lot of work to be done. And now we try to do this with National Cancer Institute to form cohort for cardiovascular diseases.
Excellent. Well, thank you so much for your very interesting talk. And looking forward to hearing the rest of the presentations to complement this one. Thank you.
Thank you.
I would like to now invite our excellent tech team to share the recording for Dr. Maureen Hatch, our recently retired expert from the National Cancer Institute.
I want to thank you for that very nice introduction and thank all of you members of the Radiation Research Society who are meeting virtually on this day instead of in lovely San Juan. And I hadn't realized what a long history our society has, but I'm very much looking forward to this meeting, although Dr. Bazika has very nicely covered all the material related to the first responders and cleanup workers known as liquidators. My talk, we're going to focus on the general population, those who were exposed to fallout prenatally in childhood and in adolescence. Here's the iconic picture of the plant at the time of the accident, but I want to focus here on events on the ground. This is the city of Kyiv, which you may know, and up here is on the border with Belarus, but in northeastern Ukraine, is the site of the plant. You can see that there is a lot of serious fallout concentration here. Also up near Gomel in Belarus, Belarus gets a lot of this, and even some in the Russian Federation. The fallout, interestingly, was not external radiation, but principally radioactive iodine-131. And if you don't know about it, I'm going to tell you a few facts. Iodine-131 is rapidly taken up and concentrates in the thyroid so that the dose to the thyroid is greater than the average body dose or any other organ. It can be inhaled and ingested, mainly in contaminated milk. And it seems, although, for instance, there was some inhalation for the first responders at the time of the accident, but for the general population, ingestion seems to be the major pathway. With children receiving the highest dose, their thyroid is small, they drink a lot of milk, so through the pasture cow milk pathway, they become quite exposed. What was known at the time of the accident about iodine-131? In diagnosis and treatment of thyroid conditions, there were no obvious problems in adults, but the data on children were very sparse. But nonetheless, it was extrapolated from adults to children, and I-131 was largely considered non-carcinogenic, at least in Ukraine. And hence, there were very limited countermeasures against I-131 in fallout. There were evacuations. The whole town of Pripyat, the the company town for the Chernobyl nuclear power plant, and also the 30-mile radius and so forth within the week or so after the accident. But there were no food restrictions, anything to try to interfere with consumption of contaminated foods, no effort to provide stable iodine prophylaxis. I should mention this in particular because both Ukraine and Belarus are iodine deficient. They don't have the right levels of stable iodine. And an iodine deficient thyroid is going to take up a lot more of radioactive 131. So I'm saying it was considered non-carcinogenic, but then time trends pointed to a problem. This is a letter to the Lancet in 1991 by Dr. Anatoly Prizhanyuk, who was a member of Dr. Bazika's Institute. And you see here, beginning with the year 1981, there are virtually no pediatric thyroid cancers. And in 1990, 3 years after the accident, 4 years after the accident, 3 pediatric cases were identified. And his letter was followed by a letter from Belarus in the following year in Nature, pointing to the same problem. And before long, there were thousands of pediatric thyroid cancers. So the number 3 may not look very big to you, but it's very large increase over what was going on before. So the National Cancer Institute became concerned about what was going on and established Chernobyl thyroid studies in exposed children in high-risk populations in Ukraine and Belarus. These binational collaborative cohort studies were called UCARAM and BELAM, respectively, and they involved in-depth clinical screening examinations every 2 years, palpation, ultrasound, fine needle aspiration, biopsy if needed, and surgery if indicated. Every 2 years from 97 to 2007, and then again in 2012, 2015. The major strengths of these cohort studies, UCARAM and BELAM, were their prospective design and long-term follow-up. Pretty much a commitment to that. Rather structured interviews, principally asking of the subjects about their movements, their residential movements to different areas, and also their intake of contaminated foods. And there were individual measurement-based doses. Everybody in the cohort had a thyroid reactivity measurement within 8 weeks of the accident. And there were urinary iodine specimens collected to try to address the issue of iodine deficiency, because it had been suggested that the very short latency between the time of the accident and the appearance of the first cases might have something to do with the iodine deficiency. There was also very high compliance with this complicated regimen of ultrasound, FNA, and surgery. And the cancer cases were confirmed by panels of experts. And the important initial results are presented here from the first screening cycle, with UCARAM having mean dose of 0.68 gray and BELAM 0.65 gray, so quite comparable. And you can see that they were substantially increased excess odds ratios, 5-fold and 2-fold. This was, even though not the BELAM was not statistically significant, these extraordinary findings caught a lot of attention. And then the continuing progress of the study in UCARAM has produced more recent results, including a dose response for 65 incident thyroid cancers, all of which I should mention were papillary thyroid cancers that had been identified in cycles 2 to 4. And the ERR per gray for cycles 2 to 4 was 1.91. Again, not statistically significant, a wide range. And the result for the 5th cycle was 1.36, and again, with a lot of uncertainty. But you have to remember that the number of cases were not large, and these were definitely interpreted as true findings. As for BELAM, which got underway a little bit later than UCARAM, but has almost 12,000 children at the time of the accident with individual thyroid doses. And its recent result is finding that for dose less than 5 gray, there's a linear dose response for thyroid cancer in EOR per gray of 2.15. But interestingly, at a higher dose, the excess risk fell. Again, let's note the 10 to 15 years post-Chernobyl, the risk is still increased. All right, so key findings in the exposed children include the fact that the thyroid cancers were papillary thyroid cancers, although lately there may be a suggestion that the follicular subtype is also radiosensitive. These appeared in children in both Eucaram and Belam and are an important, probably the most important medical consequence of the accident. Risk is greatest for those youngest at exposure, and there's also a suggestive increase in females. The dose response curve is basically linear. The excess is consistent with results from external radiation in children, as well as some earlier studies of I-131, for instance, by IR. Although our estimates are a little bit lower, they're definitely consistent, and there is no evidence for a decrease. Significant increase, decades over exposure, and again, I repeat, no evidence for a decrease. But the role of iodine deficiency remains unclear. There are opposing findings and so forth. So we don't know the answer to that yet. In addition to cohorts of exposed children, we wanted to look at those who were